So are we ready to start?
Well, I want to thank and welcome everybody to the fifth installment of the international webinars sponsored by the World Federation of Athletic Training and Therapy. My name is Glenn Bergeron. I'm the president of the World Federation of Athletic Training, and I will be the co-host of your session today, along with Oliver Coburn. We are pleased to welcome the British Association of Sports Rehabilitators in the United Kingdom as a co-sponsor. Oliver Coburn from Bassrat will be co-hosting and thankfully handling the logistics for today's meeting. Bassrat has given us access to their Zoom platform, which has made it possible to offer all of our webinars so far. We're so excited for the response to this webinar. For the first time of all 5 webinars, we've sold out on this particular one. We have guests from around the world, including Canada, USA, China, South Africa, Indonesia, Ireland, and most notably, the United Kingdom. Before we get going on on the formalities, I would just like to go through some of the housekeeping notes here. First of all, the session will be recorded and it will be uploaded on the World Federation website. Oops, sorry. The presentation will be about 60 minutes, after which time we've allotted 30 minutes for questions. And we'd ask you all to please mute your microphones and video during the presentation. Questions can be submitted through the Q&A feature on the webinar. We will be monitoring those. But we'd ask you that before you post a question, if you just look to see if a similar question has been posted already, and just like that question. The more likes the question gets, the higher the priority gets up on the list so that we can get to that question that interests people the most. At the end of the presentation, you'll receive a very brief evaluation. Please take time to complete it. It really does help us in terms of getting more ideas for future webinars so that we provide you with the information that you're looking for. At the end of the presentation, within a day or two, I think it will be, you will receive a certificate of participation for your records. I'm pleased to be able to introduce to you today Dr. Dennis Caine. And Dr. Caine is a professor emeritus in kinesiology and public health at the University of North Dakota. His research interests include epidemiology of injury in youth sport and the effects of injury and training on skeletal growth, maturation, and aging. Over the years, he's published 8 co-edited books and more than 80 articles and chapters, and served on editorial review boards for the British Journal of Sports Medicine, the Clinical Journal of Sports Medicine, the Physician of Sports Medicine, and Dr. Caine currently serves as the editorial review board for Research in Sports Medicine, an international journal, and as co-editor for Krager Publishers' Medicine and Sports Science book series. I'm also proud to say that Dennis is a fellow undergraduate from the University of Manitoba. He was 1 year ahead of me and is partially responsible for all of my bad academic habits. So I want to welcome Dr. Dennis Caine to the presentation today. I'm looking forward to his presentation. I'm going to do a stop share for these particular slides, and I'll ask Dr. Caine to share his slides with us and give us what we're looking forward to is a very enlightening presentation.
Okay, thank you, Glenn. Where do I go here? Share screen?
Right.
Okay, and then click on that. Slideshow, current slide. There we go. Can everybody hear me?
Yeah, well, we're not getting your shared screen though, Dennis.
Oh, you're not? Okay.
No.
Oh, what do I need to do?
Hit the shared screen at the bottom. Okay. On the green, says share screen.
Yeah, I'm not seeing that. Wait a minute. Shared screen. Okay, there.
Okay, and then click on your PowerPoint on the desktop. Just click on that,
Okay,
and then click on the blue square, the blue share at the bottom left of your screen.
okay.
Should say blue box with share in it.
So that's there, and then a blue box with a share in it.
Right.
I'm not seeing that. Oh, not seeing that, Glenn.
You should. You clicked on your PowerPoint on your desktop and the.
Yeah. Share screen.
Yeah, and then it brings up should bring up a little just a little square with your presentation on it. If you click on it, it'll outline it in blue.
Okay.
And then at the bottom of that portion, not your full screen, but that little the bottom of that window, there should be
Yeah.
a blue box that says share.
Got it. Okay.
Perfect. We're in.
Okay. And slideshow. Current slide. There we go. Okay.
Great. Thank you very much.
Okay.
I will mute and-
Well, thank you, Glenn. It's certainly an honor to be asked, and I greatly appreciate the effort you've made to set up this webinar. And special thanks also to Oliver for his help, and certainly an honor to be here. And I'll press forward with the presentation. So the title of the presentation is primary periphyseal stress injuries in young athletes. I'm going to go through, as I go through, it'll be a background, methods, results, and conclusions. And so I'll start with the background just to give people some idea. I'll take that down there. Okay, so background to start. So my intro, I'm going to give you a bit of background, just where I started with all of this, my interest in growth plate injuries. And this goes back to my days as a graduate student, a master's student at the University of British Columbia. And there's a picture there. It's it's a gorgeous campus, one of the most beautiful campuses I've ever been on, right there on the water on English Bay. I was particularly interested in the effects of excessive loading on lower extremity bone growth in young distance runners. And it was just around that time in the 70s that we started to see lots of, organizations sponsoring events for, well, people of all ages. And I was living over in Germany from 74 to 76, and there were what they call Volkswalks and Volkslaufs and 10 kilometer, 21 kilometer, 42 kilometer runs. And they were very popular. And by the time I got back to Canada, it was catching on there too. And so a lot of kids getting involved with distance running. But while physical activity has a beneficial effect on the growing skeleton, there is evidence that excessive physical loading might disrupt skeletal growth. And that was my concern as I saw more and more kids running and running greater distances. Results from animal studies show that prolonged intense physical loading may inhibit or stop bone growth. And so questions arising in my mind: could the stress of running long distances overwhelm the integrity of the primary physes and the lower extremities of young runners? And what is the incidence and severity of primary physeal injuries affecting the lower extremities of young runners? And that's an article there off to the right, one of the first articles I wrote or co-authored on the topic with a colleague from University of Manitoba, actually, Conrad Lindner. And here's a case report. This was the first one that I found that had to do with runners. And this is, let's see if I can move that up there. A 15-year-old male cross-country runner had been running 50 miles per week. So again, that wasn't unusual back then. A stress fracture of the proximal tibial epiphysis of the Salter-Harris type. And Salter-Harris was really, it was a framework for diagnosing and interpreting acute fractures of the growth plate. And it was adopted and people started using it because the appearance was so similar, but the pathology is actually quite different. And I'll talk a little bit about that later, but you can see there the stress fracture through the metaphyseal area leading into the growth plate. And so, from there, I moved on to the University of Oregon beginning in 1980. And I immediately sought out, just within my first few weeks there, because in already thinking ahead to the dissertation, I sought out, Eugene is a huge running center, and has been for many years, a long history of track and field there, and some top runners coming from the University of Oregon. I collaborated with Stephen Roy. He was the director of the Sports Injuries and Running Clinic of Eugene, and discussed a possible dissertation topic with him. And anyway, just trying to find out if he was seeing some of these young kids with these injuries, with these stress injuries. He wasn't. He was seeing young gymnasts with stress injuries. So he wasn't seeing runners. He was seeing a lot of gymnasts in his practice were coming to him, and some of his colleagues, Dr. Singer, Ken Singer, an orthopedist was another one. And they were treating these gymnasts with painful wrists. And so we talked about that, and he had some x-rays, and we looked at those and agreed that, my gosh, these look like some of what we've seen in the shoulders of baseball players, little leaguer shoulder, the widening, the stress, a stress reaction or stress injury. And so developed a paper over time, just a case series actually over time. There were 21 male and female gymnasts aged 10 to 17 with chronic wrist injuries that were seen by doctors Roy and Singer. 11 of those gymnasts were diagnosed with stress reaction or stress fracture of the distal radial growth plate. And you can see here, this is what we were seeing, including the widening of the radial margin. You can see here an irregularity of the metaphyseal margin as well. And so again, this was called a stress reaction or possibly stress fracture. We now understand, however, that stress-related epiphyseal plate widening begins in the metaphysis. This, with the advent of the MRI, we're starting to learn a lot more about this injury with disruption of the normal blood supply. So there's a disrupted perfusion. Widening of the physis then develops as the chondrocytes, and these are the ones that are increasing number and then hypertrophying. These continue to transition from the germinal layers to the proliferative zone when they accumulate because they accumulate because they can't calcify, and so you get that widening. It's that that insult to the blood supply that causes this difference, and so you get continued increase in number, but you don't get this transformation and into the ossification aspect as a result of this injury. And this just gives you an example here too. The widening of the growth plate is usually temporary. That's what they find. That's why these injuries with proper treatment, with rest, actually do quite well. However, there may be an associated stress-related injury of the epiphysis. The secondary center of ossification, the epiphysis, and compromised blood supply, and in extreme cases lead to osseous necrosis and deformity within the developing ossification center, and to growth irregularities in the physis. Then this just gives you an example here. This is the left hand of a 15-year-old male climber who undertook intensive finger strength exercises and climbing, of course, and ignored medical devices. And this is what we see with many of these injuries. If the treatment isn't timely, if the patients aren't compliant, then the widening and the stress continues, and then there tends to be more of a permanent type of injury. And so in this case, the epiphyseal plate was damaged, and you can see the disfiguration in the middle finger of this individual. And so just by way of background too, I'm just trying to find a way where to put this. Since overuse may involve one or more of the constituents of the epiphyseal, physeal, metaphyseal complex, it makes sense to collectively refer them as primary periphyseal or physeal stress injuries, or PPSIs. And you'll hear me, continue to refer to that throughout the lecture. You can see here, there's your the metaphyseal area, there's your physis or growth plate, there's your epiphysis, and of course, in this case, the knee joint. And so, the point here is that when we talk about growth plate injuries, and what we're understanding from MRIs is it's not just the physis that's involved. Often, it's the metaphysis and the blood supply, which is all part of this process of endochondral ossification. And there's also the epiphysis, because of the compressive forces can again affect the blood supply to the physis. So it can come from either end, in other words. So since that time, since the 70s and early 80s, when I got involved with this, the trends really have continued. We've seen increased duration and intensity of physical loading. We've seen this all around us in youth sports, especially when there's there's specialization. It's early, and then there's year-round training. Kids on travel teams. Some of these kids are on several different teams. And then they're also, in some cases, increasing the difficulty of skills practice. And we see that in sports like gymnastics and figure skating, where they keep raising the bar and the skills, and in effect, the training for the skill and performance becomes more difficult. Another thing that's going on that is really affecting, in my mind at least, the potential for some of these injuries is that children are becoming more involved in adventure and extreme sports, and mountain biking, for example, and skiing and climbing, scuba diving, and so forth. I mean, look at this picture here with this. I mean, it actually horrified me when I was at Whistler Mountain in British Columbia years and years ago, and I saw these kids. They had all kinds of body armor on, but they were driving down there, down some of these slopes that people had been skiing on. And but again, it's the that what I concern more about in some of these activities is the acute type of physeal injury that might happen, or the head injuries, the concussion. But certainly with the repetitive activities and the stress on the hand and the fingers or the legs, the runners, there's a real concern for overuse type injuries in these young athletes. The concern was so much so that we formed there was a conference in Denver and Boulder, Colorado, on extreme sports medicine, and we pulled together a group of people with interests in different extreme sports. And they all developed, critical review of the literature in those sports. And we presented that in 2018 at a conference in Boulder. And there was a theme issue of this journal, Research in Sports Medicine, that you may wish to consult with, if you're interested in this area. So, not only the outdoor sports that we're talking about, the adventure and extreme sports, but also, as I'm sure many of you know, at the Olympic level, they've developed the Youth Olympic Games, beginning back in 2012 or 2014. And so, this is helping to drive the popularity of youth sports, and they're actually including some of these outdoor adventure and extreme sports like mountain biking, the snowboarding and so forth in these youth Olympic events. And so again, the kids are watching TV. The mass media is really pushing a lot of these stunts and activities. And so, the kids continue to get involved and to train hard to get to that end. So the result is, as Dr. DeFiore talked about in his article on overuse injury of the physis, a growing problem, year-round participation in youth sports, which involve high levels of repetitive training, fosters an environment where overuse injuries are likely to occur. The concern is that the mechanical tolerance of growing bones may be exceeded by the intense and continuous training characteristic of many youth sports, because certainly, the growing bone needs activity to support bone growth. Bones will not grow and develop in an appropriate manner unless they're loaded. They have to be loaded, and not only for the to maintain the integrity of the bone, but also the growth of the bone. And they've shown in studies that where activity, for example, someone who's had an injury or they may have had cancer in one limb and they've had an amputation, for example. And so that limb isn't loaded to the same extent as the other. And you can see that they grow and develop differently. And unless they're actually weight bearing and they have a prosthetic device on that limb that was amputated on the upper limb, then you don't get the bone development. So bone development is, exercise is very important to bone development. But the concern is, of course, that with kids training involved to the extent that they are, that we're seeing some, overuse type injuries. So the purpose of this presentation is to provide an update and current understanding of the occurrence and outcome of PPSIs and what in young athletes, and looking at what is the nature and the size of the problem. This is really the beginning. So we're looking at the data and just trying to figure out, what do we know about this problem and the extent and severity of this problem. So the methods, it's, your typical systematic review using the Prisma flow diagram. And what we came out with was 126 articles with relevant data that we looked at in this paper. And so getting to the results, there were 101 case reports. So most of the data we're finding are actually in case reports. And this is a limitation of the study. There were 17 cross-sectional studies, 1 case control, and 7 cohort studies. So we'll just take you through to look at this. This diagram here just shows you our results. And you can see what's happening here. These are the reports, the published reports of Physeal injury. So this includes the the case reports and series, the cross-sectional cohort, and so on. And you can see from 1950 to 59 and how this is, with the exception of a slight drop here, but there's been a progressive increase in the number of reporting. And this doesn't necessarily translate to increased numbers of kids affected, but it certainly raises a red flag in that direction. Okay, so looking more in the results, I'm going to start by looking at case reports and then cross-sectional cohort and then injury outcomes. So this is going to be the kind of the substance of the presentation here as I as I take you through this information. These are the case reports, and there are actually 101, as I mentioned, case reports, and it shows you in the shoulder area, elbow, wrist, hand, fingers, knee, and ankle, foot. And you can see the wrist and the shoulder in particular have quite a few reports, more so than some of the other areas. And then the number of patients you can see, because the baseball was the very first one where we have published reports of this of PPSIs affecting the shoulder of Little League baseball players. So Little League shoulder, it's an overuse condition that affects the proximal humerus of the throwing arm. It's believed to stem from chronic repetitive shear, torque, or traction of forces. And these are imposed on the unossified cartilage of the proximal humeral physis. Let's see if I can just get out of that. There we go. Let's see. And so when we looked at the shoulder, again, there were 197 patients. You can see in baseball, there were 185. And other, you can see that, in these overhand sports, badminton, cricket, football, quarterback and football, gymnastics, tennis, and by football, I mean gridiron football, swimming, and volleyball. So we've seen these injuries then in a variety of kids. So, you begin to wonder, whether Little League shoulder is the proper, should we be calling it something else like overarm shoulder syndrome or something to that effect, just that, because there are a number of other athletes. But again, the majority have been baseball players. This is an example here. This is a 13-year-old boy baseball pitcher presented with right shoulder pain. And you can see in the radiograph here, you can see the widening of the radiogram and the irregularity and fragmentation of the metaphyseal area. And there's his that's the dominant shoulder. Here's your non-dominant. And this is what we'd expect to see. You can see that the boy's still growing. The growth plate is still open. But it is starting to close there. So a 13-year-old boy, probably a mature boy. And this is what we found, Little League World Series. These were, and the pitcher in particular, were often very mature, skeletally mature individuals. So there's a selection factor going on in that sport. What was interesting, Hayworth and al., this was a fairly recent publication, in their practice, they looked at the annual volume of diagnosed Little League shoulder cases over a 15-year study period in 3-year periods. And you can see it amounted to about an 8% growth in each period, with the exception of this one. But it averaged out to about 8% of growth, per study period. But this was in one practice. This was at a hospital, Children's Hospital in Boston. Now at the elbow PPSI, and this we're looking at the proximal radius. Elbow can also the distal humerus as well as proximal radius. But in gymnastics, full extension loading causes maximal compression forces to be transmitted through the lateral aspect of the radial head, which can lead to stress fractures of the radial head epiphysis. And we saw some in the 80s and 90s, but then we're starting to see some more studies just recently, like this Santelli et al. Presentation that was recently published. This is the result of the search that we found in the elbow PPSIs, 26 males and 21 females. And these were, you can see that the injuries and patients here were primarily baseball and gymnastics. And in the proximal radius, there were only 4 baseball players and 41 gymnastics patients. And then in the distal humerus, and there were only a couple of cases there. But again, an area where the elbow, and of course, we've heard a lot about osteochondrosis affecting the elbows of baseball players and other athletes where they're doing a lot of weight bearing. This just gives you an idea. So it's an example here. What I'll try and do with each of those is show you an example. This is a Salter-Harris type stress fracture. It's coming right through the epiphysis and growth plate. But again, this is a stress fracture. It's not an acute fracture. And this is 11-year-old female gymnast who's presenting with right elbow pain. And you can see there the fracture through the epiphysis. And what can happen sometimes too is you can end up, because the stress is more on one side than the other, so you can get a fragmentation, or you can, in some cases, you can get partial closure, and so a slanting there or deformity of the radial head as a result of the injury. Distal radius is another one. It's a very common one. You probably heard a lot about this in recent years. It's a common site for injury in gymnasts because of the significant amount of compressive and rotational forces on the forearm during upper extremity weight bearing. And people don't, normally spend a lot of time on their walking around their upper extremity, but certainly gymnasts do. And then they've got the rings and the horizontal bar. And so there's a lot of traction force there too. With the wrist PPSIs, we found 33 were male, and these are the patients, 65 female, and this is the breakdown. Most of them, vast majority, were gymnasts, and then there were some others, badminton, break dance, and also climbing. This just gives you an idea here. This is a case provided by Jerry Dweck, a pediatric radiologist. In California. This is a 12-year-old female gymnast with chronic physeal injury with brain widening and regularity of the physis. And now we get to finger PPSIs. and climbing. The greatest fingertip force is applied to the middle finger, followed by the ring finger. And these injuries are more recent. This is, like a lot of these outdoor sports, have become much more popular for children and youth in fairly recent years. So it wasn't really until the 1990s that we started to see this kind of injuries. The most frequent PPSI report among young climbers involves the dorsal aspect of the middle phalanx, with injury to the middle finger being most common. And here you can see rock climbing. When we break this down, rock climbing, 78 patients, and gymnasts at the hand. And again, this was Jerry Dweck, who's started to look with using MRI, that what we were seeing in the wrist, we were actually also seeing in the hand of some of these gymnasts, that the stresses were more widespread than originally thought. Here's an example. This is a 15-year-old male youth with a 1-week history of bilateral painful swelling, the proximal IP joints of the middle fingers. And you can see the what we have here, a somewhat displaced Salter-Harris type 3 fracture, in this case of the middle phalanx, and then follow-up radiograph showing fracture union start of epiphyseal closure. So gradual, with rest, with treatment, you start to see gradual very gradual return to activity and to more of a normal architecture of the skeleton in those young individuals. Okay, knee PPSIs next. These injuries are believed to result from repeated compression, rotational, shearing, valgus, or varus forces of the knee ensuing from repetitive trauma during sports activities. And there's quite a breakdown here, as you can see, with knee injuries. What's scary, though, is now as we move into the lower extremity, the knee, and there's not a lot of data on this, but there's the knee and then the ankle. We can begin to appreciate that deformity, growth disturbance, and or deformity here, if left untreated, can certainly affect the growth, the height of an individual, and in the long term too, there's concerns about osteoarthritis, as there was in the wrist and elbow and shoulder as well. But you can see the breakdown here: 17 male, 9 female, baseball, basketball, gymnastics, multiple sports, recreational, rugby, running, and soccer. What was interesting in rugby and also football, in another study, I found that the place kickers were putting a lot of stress on the knees, and coming up, there were some examples of growth plate injuries there as well. Here's one. This is a 15-year-old rugby player who'd been intensely practicing his kicking skills in spite of increased pain and swelling. Radiographs show a wide separation of the right proximal tibia pivot. And look, on the other side, the other leg is normal and asymmetrically affecting the middle side more than the lateral side. And so this caused some changes, and we'll see later about, surgery was required to correct the deformity in the upper part of the lower extremity as a result of this injury. And so again, a rugby player and a kicker. Another one is the ankle foot PPSIs. And what we found here is, a distribution again, basketball, dance, 4 patients, and these tended more to have their feet involvement, distance running, multiple sports, and then soccer. Here's an example here. This is a 9-year-old female recreational dancer and gymnast. So she was involved in both, with a 2-month history of progressive right ankle pain. And you can see here in the slides here, in the right ankle showing metaphyseal cystic changes and widening of the distal tibial epiphysis. Okay, so this is in the right ankle. You can see it there, especially in this individual. So this is stress fracture of the distal tibial physis, and there's several of these. Here's a 10-year-old ballet dancer girl with a history of 5 months of bilateral foot pain, plain radiographs, and you're probably already noticing what's going on here. Plain radiographs of the feet show segmentation of the epiphysis of the proximal phalanges of the first toe on both sides. And I think this is one that required surgery, to ultimately involve some surgery. And so these case reports and case series, that we've gone through, certainly they provide us with a lot of information about the severity of these injuries, certainly the existence of them, and the existence in a variety of sports and a variety of locations. But they cannot be used, because they're numerator based, they cannot be used to generate incidence rates of PPSI, so we can get an actual rate. And so we move on from there into more cross-sectional types of studies and cohort studies. And that's what we'll look at next. So the cross-sectional studies, descriptive cross-sectional studies simply characterize the prevalence of a health outcome or injury at either one point in time or sometimes over a period of time. And I've done both types of studies. For example, it takes a snapshot of the proportion of individuals in the population that are, for example, injured or non-injured at one point in time. What we found were 17 cross-sectional studies providing prevalence estimates of PPSIs involving the shoulder, wrist, and fingers among baseball players, gymnasts, and climbers. What we didn't find were lower extremity studies. And this is a concern because I think we really need to look more at what's happening in the lower extremity of these young athletes in the growth centers. Here's the different studies, the number of subjects, and then the overall prevalence. And I just combined the data there for you to simplify it a little bit. So in baseball, 287 subjects, diving 20, gymnastics 212, and climbing 30. And we get a range, and this is a prevalence now at one point in time, anywhere from 13.2% to 52.6%. And now what's interesting in this diving study was that it was an imaging study of these divers, and all of them weren't necessarily presenting with pain in the wrist. And so, we see the same thing with osteoarthritis. You can sometimes have, certainly the x-ray will point to it, but people may not be symptomatic. And we saw the same thing here. This was a study that I actually conducted. It was kind of the next study that as I started to work towards my dissertation, and this is one I worked on while I was collecting data for the dissertation, which kind of took me to the next level. We looked at the case study and thought, okay, well, how big a problem is this in the gymnasts that we're studying? And so I did a cross-sectional as well as a cohort study. And so here, these were, fortunately, we got the funding, and the kids were coming in every year, and we had an x-ray at the sports center at the University of Oregon, and got permission from the parents, and we were able to x-ray the gymnasts. And also we're doing a growth study, so where we were doing figuring out bone age of the gymnasts as well. So here we had 60 young gymnasts, males and females, and the radiographic valuation, and this again, at this point in time, 5 gymnasts, 4 girls, 1 boy, with stress-related changes of the distal radial growth plate. So it wasn't that high. Other studies have found higher, but in this case, and what, I talked to coaches too, and what had happened by the time we were collecting these data, it was now 1986. And from 1980 to 83, we saw a lot of cases, and we weren't looking at that time collecting the epidemiological data, but a lot of cases with these stress injuries. And the coach left. There was a coach that was working the girls and had a different approach to, and the boys, and a different approach to it. And once that coach left, then we saw a change. And so there's all kinds of reasons, I think, when we see, and that's why the more longitudinal approach to pick up the events, the incidents over time is a better way to go. So these are the cross-sectional studies, and there were several gymnastics, Chinese opera students, that included gymnastics activity. And what we found were again, not too many patients, except for Bartsky's study in the climbing. And we found some early partial closure of the distal radial physis, and a few of these are premature closure, bone bridging, indicating previous injury, and then joint incongruity with permanent impairment in the middle finger of 8 climbers. And these were all children and adolescents. Okay, so cohort studies next. Unfortunately, most cohort studies of injuries affecting young athletes provide few details about overuse injuries. And I found that too, a lot of the systems that they have for collecting data are collecting, the acute injuries. And so we're already compromised a bit there in terms of looking through the literature. So we only uncovered a few studies, and these are the studies here. And we see a variety, baseball, gymnastics, most of them were gymnastics, and we also have some climbing studies as well. And again, it gives us an idea of the, the number of cases, This one I'm going to talk about here. This was, a 50% of the cases with distal radius PPSI. So we'll look closely at that one. This is the dissertation study. Remember when I went to Eugene, I was looking for a dissertation topic. I thought it would be with runners, and it ended up being with gymnasts. So there you go. And I stuck with gymnasts, but I've gone on, of course, and looked at other sports as well. In fact, Glenn and I recently looked at a ballet study of young dancers, male and female, at the Royal Winnipeg Ballet School. So there's the paper. This is what I found in that study. Overall injury to 3.66 injuries per 1,000 hours. 43 of the 50 gymnasts sustained 147 injuries. So 7 gymnasts did not sustain injury. More than half of the injuries were overuse. And a lot of those were pain. Even the doctor, at that time, they didn't have the MRI and they didn't always use x-rays. And so they would indicate pain. 4 of 147 injuries were PPSIs involving the distal radius. And overall, there were 6.1% of the injuries sustained were primary physeal injuries. There were other injuries in that study. There were physeal fractures, these sudden injuries, the physeal stress injuries, the apophyseal injuries. And I should say, actually, those are the physeal fractures and stress. Those were all PPSIs. But yeah, we saw a lot of kids with Sever's disease or Sever's, and then, the sudden injuries like you see there that all affect the growth plate. This is the one I was going to tell you about. This is a study of Chinese gymnasts. This is going back to the early 1980s. And where they followed, these were top level elite gymnasts that they followed over time. They're both males and females. And you can see here the stages. They actually developed stages where they, by stage 2, there was, here was the pain, and here was decreased range of motion, stress changes. And here we see a relatively lengthened ulna, or similar to Madelung deformity, and wrist joint presents with arthritic changes. They didn't talk about the degree of arthritic changes or have a reference for it as you'd see today. But at any rate, this was the report. And so it is interesting because you see these, I think it's the most, the type of study that really follows, and they were actually taking x-rays of all the kids at intervals. And in most studies we see out there, the only kids that will be x-rayed, in North America or Canada or England, would be the kids that were actually injured, and where it's expected that they would do that. So, that's a difference there in that type of study. Okay, looking at injury outcome now, and we'll look at management, growth disturbance, surgery, and long-term health outcome. In the case literature, and I think this is really important here, is that most PPSIs were generally treated with complete rest from the exasperating activity to allow healing. And it worked. Time off sport before return to activity ranged from 1 to 12 months. That was the range, and depending on time into treatment relative to injury onset and patient compliance. Studies report the various use of treatment modalities, sling, casting, crutches, and so on, to help assist with that. Many studies also report the use of physical therapy and related programs to improve strength, range of motion, and movement mechanics. Here's one study. This is now looking at growth disturbance and deformity. The widening of the physis is usually temporary, and the attendant epiphyseal and metaphyseal blood supplies are essentially undisturbed. And that's what we talked about earlier. However, they may be an associated stress injury of the physis, which may further compromise blood supply to the physis, and in extreme cases lead to growth irregularities. And here's a study by Demawolf et al. This is a recent one, and they found lateral distal femoral hemiphyseal arrest secondary to chronic repetitive microtrauma. And you can see there, and surgery was used to follow up and help correct that. And so that's a growth disturbance and deformity. These are when I looked at the number of patients with growth disturbance, there were 53 total out of all of the gymnasts. And so, that's a fairly low count when you look at, I think there were 473 injuries. So 53 of those were associated with growth disturbance. And you can see they're involving all the joint, the shoulder, elbow, wrist, hand, fingers, knee, and ankle, foot. And we'll just go through and show you some examples. This is actually a gymnast who had an premature closure and ankle varus deformity of the right proximal humeral physis, and a 15-year-old male, and an elite level gymnast. And that gymnast, by the way, was able to get back at, with rest, even in spite of the deformity, was able to get back to international competition. Here's the x-rays of the proximal region of the humerus and the physeal enlargement. There's the left, there's your normal physeal plate. So this is the gymnast again. And there's the deformity in varus that you're seeing in the in this shoulder, but not in the left humerus, which is the uninjured shoulder. So you see that deformity resulting from the injury. Here's another one. This was actually came from a study that I conducted a few years later, well, quite a few years later than the than the Eugene study. And this was a gymnast. She was 14 and she had chronic wrist pain. And what we found was really interesting. It was actually, she had seen a chiropractor initially, and then she was sent to an orthopedist. And we see here a premature closure. There's your left wrist. Here's the wrist with pain. And what's happened is the distal radius is closed. The ulna is open, and it's still growing in effect. And so we had a premature closure there, and she ended up having surgery as well. And we'll look at that a little later. Here's a 15-year-old climber with chronic pain in the proximal interphalangeal joint of his middle finger. And you can see there the stress fracture, through the epiphysis and into the growth plate. And you can see it there on the MRI as well. And then the deformity in the finger. And so these are some problems that they're finding in young climbers. This is the knee. This is 11-and-a-half-year-old girl plays competitive tennis. Radiographs show physeal widening of both medial distal femoral physes and both medial proximal tibial physes. Pardon me. And you can see here the injuries. And now again, this is a young tennis player. She continued to play tennis. And she was not compliant. And then what you see over time is a relative varus alignment of both knees as a result of those injuries, even though they're gradually healing. And so there was an effect in the growth of these bones. And you can see here, this is now the girl at 17 and showing development of relative varus alignment of her lower extremity. So there she is when she's younger at 11-and-a-half, and then older. And so you can see the result of the PPSIs, and then extending into the leg. These are radiographs and MRI of the right foot, and you can see here we've got a short metatarsal and growth plate closure of the head of the second metatarsal of the right foot. And so this is, you can see that here. And, pursuant again to growth plate damage. And then so you get the shortened metatarsal as a result of that. You can see that here. So gradual change. And there's the result there, premature growth plate arrest of the second metatarsal. And of course, the young ballerinas are on their toes, on point. And this, if this happens, there's some debate about when this should start for young ballerinas. What age or bone age should they actually be beginning with this, because of the potential for growth plate problems. And now moving on to surgery, of the 473 patients treated for PPSIs, 31 patients, or 6.6%, underwent surgery for their injury. Here's the gymnast that we saw in our study, and she had an ulnar osteotomy. so they could correct that and create a more normal joint and hopefully protect against eventually osteoarthritis. This gives you an idea of the surgery here. Let's see, whoops, back up there. Number of patients and so on. So again, each of the areas, the regions, the shoulder, elbow, wrist, and so on are affected, but to some, these are the number of patients and these are the number of surgeries. So only one surgery out of all those shoulder injuries, but the surgeries are more common, as you'll see, amongst the elbow and the knee, particularly the knee amongst the kids followed. Here's a 15-year-old rugby player, and I showed you a picture of him earlier, and he had that widening of the proximal tibia, and so he ended up having varus deformity and corrected with a wedge opening osteotomy of the distal femur to correct that. And so those are kind of surgeries. So long-term health outcome. PPSIs can counter the beneficial effects of sports participation at a young age if the child or adolescent is unable to continue to participate as a result of the residual effects. As we saw, most patients are return to activity. Timely return to the sport following PPSI injury and treatment appears common with sufficient rest. There are, however, reports of patients who were encouraged to take up another position in their sport, at least temporarily, and to give up their sport altogether. But these are in the small minority. So most cases seem to do well and to respond well. The injury responds well to rest. And this is just an example. Here's this 15-year-old, 7-month boy who's a football place kicker. He's had the widening there, the lateral physeal widening of the distal femur. And then over time, and here's 3 months, I've underlined that, of after immobilization of the knee shows near complete resolution of physeal widening. And of course, from there was a time when people recommended to wait until the athlete's physis closed before returning. But I see more aggressive pattern now in the research where people are going back, but it's very gradual. And like I say, in some cases, it's a different position, until they are symptom-free. In one study of Little League shoulder treatment recommendations, including rest in 99% of the cases, physical therapy in 79% of the cases, and position change upon return to play in 26%. Average time to full resolution of symptoms was 2.6 months, while average time to return to competition was 4.2 months. So I see that, like I said initially, we see a range of 1 to 12 months depending, but I more often see, 2 to 3 to 4 months for resolution of the symptoms and return to play. A concern related to PPSIs is that acquired length discrepancy, angular deformity, or altered joint biomechanics may cause long-term disability. Specifically, OA may result from chondral damage at the time of growth plate injury, articular incongruity, or joint malalignment. So this is a problem. When I looked at the literature, though, really what we see is most of what we know about osteoarthritis in former athletes. This is looking at it longitudinally, is that these are women that have soccer injury, ACL injury, and then follow up. And so they're ending up with osteoarthritis or early onset osteoarthritis at an earlier age than what we'd see in the normal population, a much earlier age. These are acute injuries. We know very little about these traumatic, or I should say overuse or chronic injuries. The little bit that we learned from the Chinese study and showing some, and also from the climbing study, what Schoffel found, there were signs of early stage osteoarthritis in 6 climbers. And I think there were about 29 that they were following. Pardon me. So limited longitudinal research involving elite level gymnasts and rock climbers attests to the potential for early onset of OA to develop secondary to PPSIs in young athletes. However, the incidence of this is largely unknown. as something we looked at in an article and a presentation in England a few years back. So conclusions, young athletes engaged in a variety of sports, especially at advanced levels, may sustain PPSIs involving the shoulder, elbow, hand and wrist, knee, ankle, and foot. And I should go back, and these can be sustained in a number of activities, as we're finding too: gymnastics and baseball, basketball, soccer, football, rugby, climbing, some of these outdoor sports. I mean, it's endless. And so I think we need to be, careful and acknowledging that these injuries can happen in a variety of sports. There's some evidence which indicates that PPSIs are becoming more common, as we saw, but again, these were reports on these injuries and not necessarily incidence data over time. So epidemiological studies are needed to investigate this possibility. Most PPSIs respond well to rest and timely treatment. However, in extreme cases, some PPSIs may progress to skeletal growth disruption and deformity. So rigorous longitudinal epidemiological studies of young athletes are needed to provide information on the incidence and outcome of PPSIs. Noticeably lacking in the published work are studies reporting prevalence and incidence rates for lower extremity PPSIs. In the absence of large-scale coherent research, one cannot help but wonder how many PPSIs go unrecognized. And I showed this picture too here, just to give you an example about just how involved and passionate some of these young kids about their sport, and they will practice and practice and practice, and of course end up with some of these overuse problems. And it's hard to manage and quantify. In baseball, I know they reduce the number of innings, they've reduced the number of pitches, but many of these kids will go out and they'll practice on their own and they'll throw and throw and throw. And we see the same in other sports as well. So again, it's something where vigilance is certainly recommended. Okay, I think that's it. We're just a few minutes short of the hour, but we're certainly open for questions.
Dennis, thank you very much. Would you mind just stopping your screen share for me? It should be a red button at the top. Just so that,
Yep.
Perfect. Just so that while we're having a chat, everybody can see us. So thank you. We've got some fantastic questions in already. Some really
I'll do my best.
Yeah, and I've got a couple of my own as well, following on from your presentation. So
okay.
Let's see if we can work through everything. So Gail, first of all, thank you, Gail, for your question. She's asking, at what age is it recommended to start sport-specific training? On a weekly basis, I see youngsters with repetitive overuse injuries from playing the same sports, and they also seem to be getting younger and younger when they specialize.
Yes, and that's a good point. I know there's a lot of concern about that too, and a lot of controversy about that. I know there is, and of course, to be competitive, this is part of it. They need, the children, especially as they get into their early teens, need to be, sticking with that sport and practicing. But at least initially, what I'd recommend is that children have, a variety of activities that they can participate in. And if it's time, and time's as a parent, I understand that, and parents or time is a factor, and the cost of this is a factor. But if that way, you're not seeing the exposure is the key here. And so if you can vary the exposure, so it's not, a little bit of dance, but maybe they're involved in a bit of soccer as well, that type of thing. And that's what I did with my kids too, is they were involved, even though they both eventually went into competitive swimming, but early on, there were 2 or 3 different activities that they were involved with. And so we tried to vary the loading and limit it a little bit. So that would be my recommendation.
Variance in the loading between the upper and lower extremity as well. So swimming would be a great example for a kid who plays soccer or football and has lots of lower extremity loading the rest of the time.
Yeah, balance that with swimming, for example, or or even rock climbing. I guess there's a lower extremity too, but a lot on the fingers. Yeah,
I'm going to throw one of my questions in, just kind of on topic with the amount of loading, and I wanted to touch on strength training and ask you, what To what extent do you feel strength training is protective for these kind of injuries? Or conversely, do you feel that it's that extra contributory load and could therefore lead to an increased prevalence?
Yes, well, I think immediately of the picture I showed you of the hand and the middle finger of that young climber, and the swelling and around in the middle finger there. And there is someone who is doing a lot of extra exercising for that finger to load it, and in effect overloading it. And so, yeah, you have to be careful. But weight training, again, that has undergone a lot of discussion and controversy. And I think it's generally recommended, but just to be very careful. And so that initially the child might use their body weight as one might do in a push-up, for example, but to use their body weight as a way of gradually increasing the weight. But yeah, if you can see in the physical therapy, for example, and you'd know more about this than me, you're trying to strengthen the musculature around the joint so the bones don't take so much of the loading. And so that, I would think that would be important. But like I said, I think you might have something to add to that.
Yeah, I mean, certainly from a strength training perspective, we have the position statement from the UK SCA in the UK, that it's very clear that strength training is a positive for adolescents if coached properly and they have the correct technical capabilities and it's coached and everything else.
Yeah.
It was more just touching on whether in the specific context of physeal stress injuries, it can be a protective. And I guess if with the caveat of it's done properly, I guess the answer is yes.
Yeah, for sure.
Brilliant.
There have been some, I think fairly recently, some consensus statements that have been published with regards to strength training and when to start and what procedures to follow and so on. So that information is out there, and it's fairly this is published by international organizations. And if this individual wants to follow up with me, on an email, for example, I could certainly pull that out and send that to her.
Cool.
Or him. Yeah.
So let's get to Mick's question. Thanks for your question, Mick. It's got a lot of likes as well. It's got 11. So that a few people want the answer to this. So with regards to associated factors for proximal tibial fractures, you mentioned the link with severs. Is there anything you've seen which shows a correlation with Osgood-Schlatter's or other adolescent-specific pathologies?
Yes, yeah, there are certainly articles where you do see that, like the Osgood-Schlatter, and where the growth plates are involved as well. I've seen several articles like that. And Tony et al., it was a fairly recent publication, talked about that. Yeah. Cool. So I've tried to kind of focus in on the Physeal ones, but yeah, I've definitely seen that. Yeah.
Okay, cool. So some reading for you there, Mick. Tony et al.
Yeah.
Go and dig that one up. Patrick's come in with a probably 4-part question, I think, from what I can see. So we'll maybe work through this one in bits. So with the follow-up studies, were there any psychological assessments linked to return to activity? So self-esteem, confidence, and assessing that readiness, that aspect of readiness for return to activity?
I see. Yeah, no, not in the case. They stuck closely to the physical and physiological aspects, but in any of the case reports, and I haven't seen that. I haven't seen that in any of the literature to do with growth plate injuries.
Okay. Yeah. Cool.
But there's a study. I mean, if one had, it might have to be smaller scale because again, it's difficult sometimes. Well, it might be with for example, what one of my colleagues is finding in Germany, Dr. Schulfel is his name, Volker Schulfel, and he works with the German junior national climbing team. And he works with these individuals, he's coaching, but he's also their team physician. And so working with these individuals over time, he's published a fair bit on this, but it's that type of thing that I would see where an opportunity for someone to get involved and then follow these individuals that he's working with who are still, children, adolescents, and to follow them and then look at the the psychological or psychosocial aspects of return to practice and so forth. Yeah, I mean, there's certainly, I think, a lot of potential there for further research. Yeah, but you'd need to type, and I would imagine Great Britain as well, or wherever this individual is coming from. If there's a national team like that or of gymnasts, that if you could get involved with these advanced groups where they're training a lot, where you'd see, because the exposure is greater, you're going to see a greater prevalence of some of these kinds of physeal injuries.
Yeah, no, I'm kind of linked into this as well, and it's one of my favorite topics around communication with athletes. So how would you recommend that we communicate with parents and young athletes about, particularly where they're not compliant with the rehab protocols, especially those that concern complete removal from activity, where there'll be worries about isolation, deconditioning, etc.
Yes. Yeah, and it's typical, and I think there's been a gradual transformation of, I know when I was following these gymnasts early on in the early 1980s, and I remember spending a lot of time watching, taking notes and so forth, interviewing the injured gymnasts in this case, but also, part of the culture was no pain, no gain. And I think what the children what's really important for them to hear is that's counterproductive. And especially if we're talking about any pain around a joint, any pain or swelling around a joint, which could imply, a physeal stress injury. And so, and what's really important for them to hear, and I think they do too, is that they've got to rest it. If they don't, it just gets worse. And I think in many cases they do, because what I read about in many of these case reports too, is they are simply, because of the pain, they are unable to participate. As with all of us, I think many of us find we sometimes go back, we get injured and we go back, especially overuse type injuries, and then we go back too soon and we have to backpedal a bit. Okay, slow down a little bit and try again. But I just think to emphasize that is to follow the guidelines given by the therapist, the athletic trainer, the physical therapist, the physician, and for the patient to be as compliant as possible, because what's showing up here very clearly with these growth plate injuries, primary physeal injuries, is that the people, where we're running into trouble, where there's, deformity or growth disturbance or sometimes surgery, it's where they've been non-compliant.
Yeah.
Yeah.
How high up the priority list is using lower load methods of exercise to maintain somebody's physical condition in that period where they're laid off from the kind of aggravating activity, or do you completely leave them alone and worry about the deconditioning later?
Yeah, it's interesting. I think it depends a lot on the injury and the location of the injury. I remember watching the gymnasts, and it may be a wrist injury, for example, but they would find other ways to keep active. So it depends on the sport, I think. They would tape or immobilize the wrist, for example, but then they would be, find other ways to be practice some moves where they didn't need to use their hands, kind of thing. But it's very sport specific, so for the baseball player who's got a shoulder injury, I'm not really, certainly they can be involved in some activities as long as it's not jarring the shoulder, some running, some stop and start, some catching. I don't, with the other hand. Yeah.
Athlete by athlete basis, and kind of
Yes.
take each context as it comes.
Yeah.
Now,
I always remember when I was a student at University of Oregon, actually, now this wasn't a growth plate injury, but these were stress injuries. And Alberto Salazar, he was a marathoner, well known in those days in the 70s and early 80s. And I'd never seen this before. I'd be over at the pool swimming, and I'd see Alberto in the deep end of the pool running with a weight belt on. And, that was his way of continuing to exercise, but without loading his lower extremity.
Yeah. Now world-renowned running coach for various reasons.
Yes. Yeah. Like you said, yeah, for various reasons. Yeah. Yeah.
Okay. So anonymous question. And I'll give it my best interpretation. So whoever's posted this anonymous question, if I've slightly misunderstood it, please correct me. I think what you're asking is around coaching error. So that we're saying with these PPSI injuries, do we know from the research whether it's a training load issue that's happening on the court and the pitch, or does it come through additional training from pressures that the athlete is doing in their own time? So that it's happening in individuals where there's an extra motivation and they're taking it upon themselves to do even more training and therefore overloading, or is it coaching error?
Yes, yeah. Yeah, that's a good question. And as I referred to it, some of the difficulty they're finding in baseball, you know, they've made rule changes, and I think with some success too, you know, by limiting the number of pitches and, you know, building that consciousness in their young players, limiting the number of innings that they can pitch. But there are still those children that are going to be off practicing and you know, and the repetition, the exposure. So continuing that. And so how do you deal with that? I think for a coach to, you know, certainly to do what they can to minimize the potential for training area, but also to counsel the young athletes to, you know, to rest that limb, that joint, you know, as much as they can. Yeah. And I think swimming too. I know my daughter, my granddaughter is an active swimmer, and they've changed too. You know, so the thinking has changed a lot. It used to be a lot on mileage, you know, putting on the yards or meters. You know, swim, 2, 3, 4,000 yards in a practice, and that's changing now. That thinking has changed, and so they're doing more land drills and you know, some light weights and so forth, but doing things that will you know, facilitate their performance in the pool, but not just repetitive breaststroke or front crawl or butterfly, that kind of thing.
Yeah, bro. I'm gonna slip another one of my questions in and be
Okay.
selfish, just because it's something I don't think we've touched on. So when we're looking at this, we've talked a lot about training load. Are there other intrinsic factors? So, and I'll give some examples in a second that can contribute to which athletes develop these kinds of injuries. And I was thinking specifically along the lines of body weight and body composition, and any nutritional elements, so potential deficiencies or athletes with a poor diet, perhaps.
So, what is?
Yeah. So, do we see any associations between perhaps athletes with you know, less favorable body compositions in the development of these injuries, or athletes that are deficient in a particular vitamin or mineral in the development of these injuries?
Yes, yeah, certainly a very interesting question, I think, because you know, and some of the early research too looked at, which relates to this, I think, too, is the body type, and are some body types not only prone to more success, but also prone to you know, reduced injury. You know, are we going to take a football lineman, for example, and try and turn that person into a marathon runner? Or are we looking at a lot of potential for, you know, eventually osteoarthritic changes because of the weight on the knees and so forth? And so, you know, the body typing and so forth. But yeah, I think all of that's really important. We found that with studying, I didn't look at that specifically, but I worked with people who were with the gymnasts that were looking at their nutrition because of the concern about the kids. And in ballet, you see this too, where there was concern about them not eating enough. And so, you know, it would affect their, you know, now we're getting back to talking about the bone, because the bone would be, you know, without the proper nutrition, the calcium and nutrients and so forth, that the bone would, you know, be at increased risk of stress fractures. So that nutrition component is yeah, very important for them, and help to reduce risk of, you know, if we're talking about the skeleton, of skeletal injuries, over stress-related skeletal injuries.
Yeah, I was thinking of it purely from a kind of a physics perspective, so force masses acceleration, right? And a heavier athlete therefore exerts more force, and the typical example is higher ground reaction forces in heavier runners. me being one of them. So it was purely linked to that, but very interesting to talk about. Sophia asked a great question, and I think we've touched on elements of the response already. But there's a particular bit in there about working with physicians. So what advice would you give to Sophia when she's working with physicians who want to keep athletes completely out of the gym? Because she's finding that she struggles to motivate them and keep them kind of mentally in a good place when that's happening. So, for instance, should she be looking to have some dialogue with the physicians about what it might be beneficial to do rather than completely laying them up? Just a thought.
Yeah. I think, well, that's certainly that dialogue is really critical. I think between, the athletes, the young athletes, but their coaches, their parents, the trainers, the physicians, the whole healthcare group. That there's ongoing dialogue there is really important, I think. I was thinking too, just to step back for a minute, we talked about the athletes and concerns about injury because of body type or the loading, the physics involved, and I know there was in fact I did a theme issue for the British Journal of Sports Medicine. This was back in 2010, but one of the authors focused on obesity, on overweight, and the concern about so many of the kids today are more endomorphic than they used to be. They're heavier, and that this is we're seeing an increased incidence of ankle fractures and knee problems in some of these young athletes because of this extra weight that they're carrying with them. And that has a lot to do with diet of young people and so forth. So just a thought.
Factorial.
Yeah.
Jack's asking, I think I already know the answer to this one actually. Could you please provide us with some titles or some journals where we can find the study that you performed or the research that you performed with the extreme sport? Where can you find out more about that?
On extreme sports?
Yes.
Yeah, just a second actually. Where am I?
Always prepared. Love it.
Yeah, just right behind me. There's a book here. This is Adventure in Extreme Sports. This is by Omar Maidan, and he's actually the physician. He's an orthopedic surgeon at the University of Colorado, and he's the one that really organizes these conferences on injury and adventure in extreme sports.
Just give us that title again, Dennis. What's the title again?
Yeah, the title is Adventure in Extreme Sports.
Adventure in Extreme Sports.
Epidemiology, Treatment, Rehabilitation, and Prevention. And the editors are Omar Maidan and also Michael Carmont. And Michael Carmont, I think, is a Brit.
Oh, cool. Jack also says, thank you, what a legend. For getting up in the book there.
Yeah. So there you go. There's a picture there of, I don't know if it comes through very well.
No, not too clear.
Yeah.
Not too clear. Okay, so we've still got a couple of questions to go. So let's get to it. I'm not even gonna paraphrase Steve's question. I'm just gonna to read this one out. It's quite long. So thank you, Steve. In baseball players, it's appreciated that humeral head retroversion may actually be a sports performance selector, suggesting that those who participate at a higher level exhibit this bony adaptation. In most baseball players, due to appropriate load management, this adaptation is asymptomatic or perhaps underreported. Are there any long-term studies looking at shoulder pathology, quality of life in professional baseball players that could or may be suggestive of long-term issues linked to humeral head retroversion?
Yeah, I'm not able to answer that one in any kind of informed way. I've read a little bit about it, but I'm just not on top of that body. Yeah, I know that's
a great answer.
Yeah.
Yeah. Steve, you might have to do some of your own research there, mate. Okay, so Last question that's been posted from Brian Metcalf. Unless there's any more, guys, we've maybe got 4 minutes. If you want to get any more questions in, do post them. If not, it's okay. But, so Brian says, when looking at power, strength, and endurance specificity, which are causing the most issues?
I'm sorry. So power, strength, and
power, strength, endurance. So I guess what we're doing there is perhaps categorizing sports into different areas. So though power sport, endurance sport, strength sport, where are we seeing the most issues? I think that's what Brian's asking.
Yeah. Power, endurance. I think for overuse injuries, it's more the endurance sports. You know, if this we're thinking of overuse, and particularly overuse that could cause trauma to the growth centers in kids. It's the the constant repetition. Whether it's the throwing or the rock climbing, the bicycling, the mountain climbing, and so forth, all of those, it's the, as we found even with those examples of those rugby players that were the kickers or the football place kicker, repetition over and over again that's causing the stress. And so I would think for the topic today that it's really more the endurance athlete. And sometimes too, when you look at the training for, soccer, for example, or football is called in many countries, there's a lot of repetition there, the running, the stopping, and there's concerns about, the effect of all of that on the growth centers in the knees and hips of those young individuals. And so, yeah, that's where I would tend to lean.
Super.
Yeah.
Awesome. Right. Well, that's all of our questions. We've got no more coming, so I won't take any more. We'll just kind of finish up with a little bit of the housekeeping. And I think the questions in particular have been excellent and really engaging. So thank you very much for sticking with us long enough to cover all of those. I really appreciate it. And the presentation's been wonderful as well. So thank you for joining us. I've been asked by Glenn. Glenn's had to leave early, unfortunately, due to other commitments, but I'm just going to do a really quick run through as an introduction for anyone who's not familiar with the World Federation of Athletic Training and Therapy. WFATT is an association of associations. It's currently celebrating its 20th anniversary, and it's dedicated to the promotion of the profession of athletic therapy and training worldwide. There's currently 44 members, including 29 academic institutions from 12 countries on 5 different continents. All the information you need to know about WFATT is available on the website, which is WFATT.org. And there's also information on there about how to become a member as a professional association or academic institution. Personally, from BASRAT, we've co-hosted this evening. We're the professional association and regulator for sport rehabilitation in the UK, and you can find out more about us on our website, basrat.org, or on our Twitter @basrat.org. Follow our Twitter, we'll keep you up to date with all of the events that we've got coming up. So we have another webinar running shortly with Josh Quigley, an aspiring professional cyclist who's going to take us through his kind of mental, stressful journey of recovering from injury after being in a 70-mile-an-hour crash whilst cycling across the USA. He's recently become a world record holder, having completed the Scotland 500, and he's going to talk us through his journey from obtaining his injury all the way through his rehabilitation to now being a Guinness World Record holder.
Wow.
So that one's going to be interesting. We're going to get the athlete perspective for a change, and I'll be doing a bit of interview style with him. So thank you once again, Dennis, for joining us.
Thank you. Real pleasure to be here. I appreciate being invited. Thank you very much.
No, absolutely no problem. It's been really good, really informative. The questions have been great. So thank you very much. Just as a note for everybody, we will be sending you out a follow-up email that will arrive with you tomorrow. There are some resources in there. The recording of tonight's webinar is going to be posted on the World Federation of Athletic Training and Therapy website, so it will be available to watch back if you want to come back and reference any points of the presentation. And we'll be sending you out a certificate within the next 48 hours or so as a certificate of attendance. That's everything from me. So we'll leave it there. Dennis, I'll say once again, thank you very much. I'm sure we'll have a chat soon. And
Sure.
it's been a pleasure.
Okay.
Thank you.
Thanks, Oliver.